Following the operation, a typical hospital stay can be around 2 weeks. And at Sunderland, there's continuing contact and lots of support.
The most noticeable thing that patients find when they wake up is that they will be breathing through the tracheostomy on the front of the neck. And they won't be able to speak at all. They'll be able to communicate in the immediate post-operative period by mouthing words to the nurses or to their family, or by writing down words or phrases or sentences.
And I just had nothing except a writing pad and a pen. And it was very, very frustrating. Your mind moves much faster than your hand.
The person themselves obviously need the support and love from their family. It's a time when they are just recovering from anaesthetic, surgery, and it does take the first day or 2 days for the person to actually recover and start to feel more like themselves.
I personally didn't have any visiting. I didn't want them. I felt the way I looked, the way I felt. I just wanted to be on my own.
Hello, Jennifer. Hello, Margaret. Hi. The amount of tubes and apparatus can come as a bit of a shock to both patient and early visitors. But if you know what they are, it's not so daunting. Firstly, you may need help with breathing, so oxygen will be available. But remember, breathing is now through the stoma, so that's where the oxygen mask needs to be placed. There'll be 1 or 2 tubes coming from your neck to near the incision. These drain off blood clots and excess fluid from the neck wound. There'll be an intravenous drip on your arm, which is there for about 24 hours after your operation, to give you fluids until you're well enough to take fluids down this tube, the Foley catheter. More about that in a moment. There'll be a monitor recording your pulse, blood pressure and so on. This has leads attached to various parts of your body. Some patients need a urinary catheter, and all patients will have tight stockings to prevent thrombosis, blood clots in the legs. For the first few hours after the operation, a nurse will be in constant attendance, checking tubes and machines, recording readings and attending to your needs, such as pain control and clearing and cleaning your stoma. The head and neck nurse will also be available for specialist advice. This will include help in getting through any difficult patches. For example, many patients find they hit a patch of low morale 2 or 3 days after the operation. Specialist nursing really can help.
I'll see you either later this week or next week.
There's also the additional problem post-operatively of feeding because the gullet has had to be repaired. We don't allow the patient to swallow for perhaps a week to 2 weeks until we know that that repair is healed.
And during that period of time we do a method of feeding which we call enteral feeding. It's feeding via a tube, and it's a fluid feed that we administer, commencing at a very slow rate at the beginning and developing over the days until we are actually able to commence diet.
The fluid is a liquid food substitute, and in enteral feeding it's taken through a Foley catheter. That's a tube that takes the fluid feed through a valve at the back of the stoma and straight into the gullet. This allows time for the pharynx to heal. The pharynx usually heals in around 7 to 10 days, and at that stage there's a dye test, which involves swallowing a little coloured dye to check that there are no leaks. When that's been checked, food can be taken once again by mouth. Everyone heals differently, so you shouldn't be disheartened if it takes a little longer. But a typical time is around 10 days.
After the operation, it was about 10 days before they decided I was healed up enough inside to be able to eat and drink. And it was beautiful. It was heaven. You got to eat very slowly. No, you can you're not as quick as what you formerly were.
Each individual in regard to wound healing can be different. This can be due to many different factors, partly due to age, partly due to their own body system, and also due to the fact that they may have had treatment such as radiotherapy prior to surgery, and this will slow the wound healing process down potentially.
Well, when John came out of hospital, obviously all of these tubes and bottles had disappeared. And you think, oh, he's out of hospital, everything's going to be fine.
First night at home, I went to bed. All he said,
Are you all right, pet?
when you can't, in the dark, write a note. So what we devised was, 1, squeeze for yes, 2 squeezes for no. If there's no squeeze, get the ambulance.
So let's now think about the ways in which you might be able to talk after the operation. There are 4 methods, and partly it's patient choice, but to some extent the choice may be limited by the type of surgery that's necessary. You'll remember from earlier that before the operation, it's the larynx that produces the basic sounds. Using our tongue, teeth and lips, we can articulate these sounds into words. After the operation, we need some form of replacement for the larynx. But articulation works just the same. And the sound will still come from your mouth. By the way, accents stay the same. Perhaps the most common method is the valve. This is a silicone valve fitted into the throat. If you close the stoma, usually by placing a finger over it, the air you breathe out is forced through the valve and up towards the mouth. The air causes vibration of the upper esophagus, and this makes a sound. Here are some people using the valve.
I'm speaking now with the aid of a valve. This is the valve voice.
The valve is also known as surgical speech restoration. The second method of speech after laryngectomy is called esophageal voice. In this method, some air is taken into the space behind the mouth called the pharynx, and then it's expelled to make a noise. The technique's a bit like burping, but the sound is speech.
Esophageal voice, which I'm using now.
The third method is to use an electronic larynx to set up the vibrations.
I'm using the servos, which is a trade name for the artificial larynx.
Finally, there's silent articulation.
That isn't really a feasible option for most people because it can't be used over the telephone, and it's quite difficult if people are not very good at lip reading.
So there you are. 4 methods. Not all are suited to every case, but there is some choice, and you'll get the opportunity to discuss the options with the specialists at the hospital.
Our policy in Sunderland is to, as far as possible, to offer valve voice restoration as our preferred method. It has a number of advantages. The voice is louder, it's easier to understand, the sentences and phrasing is more sustained, and it's a much easier technique for the patient to learn rather than some of the other methods.
Yeah, well, I was fitted with a valve shortly after my laryngectomy, but unfortunately I was unable to produce a voice, which was a bit disappointing and puzzling.
It can be quite disappointing at first if the patient is expecting to have the valve in and speak straight away, and we're there to encourage them and to help them to understand that it doesn't all happen overnight. They've got to take the time, and it does vary. People vary in how quickly they learn to use the valve.
Well, the learning was remarkably easy, I thought. I thought it would be very, very difficult indeed. And then suddenly one day I had the valve fitted, and there I was talking.
In excess of 85% of people long term will end up with a valve, but some people don't.
When I attained esophageal voice, which I'm using now, it was probably one of the most satisfying moments in my life.
However, we have to be realistic about esophageal voice. Research does show that you tend to get less volume and you can be less fluent with esophageal voice compared to valved voice. Esophageal speech can also be very tiring.
With electronic larynxes, it looks easy. It looks like you should just pick them up and speak with them. They're not like that at all.
I'm quite happy the way I communicate now.
And again, patience is the thing that people need. Patience and perseverance.
With practice, speech can be very good, and most people find little difficulty using the phone.
Hello, I've just had a phone call from Sandra.
Most people will end up with a valve, an electronic larynx, or esophageal voice, or maybe even a combination of two of those if they choose.
There is no best method of communication. It's what the individual is happy with.
We're here to encourage choice, not to dictate to people. Whichever method of communication the person ends up with at the end of the day, it may be due to medical factors stopping them from having a valve, or it may be due to personal choice. Whatever the method of communication that's chosen, we have to find something the person is happy with and adjust to, and that's what we're there for, to help them adjust to and to learn that method of communication to the best of their ability.
Coping with illness is obviously challenging for the patient, but coping with the patient can be a challenge for their families. But there is help. In particular, the specialist head and neck nurse will provide support for both patient and family.
Does Mr. Stafford know about that?
Yes.
Well, they get very, very frustrated, and they get very, very bad-tempered, and they have terrible mood swings.
When I was in my down mood, couldn't speak and that, and I'm shortly getting out of hospital angry and frustrated, and I was taking it out on my good lady, my wife. I was remember my son come in and he's, oh, how are you? I was looking at him, I couldn't speak properly. No, he says, why? He says, I'm going to tell you something. He says, if that surgeon hadn't cut your throat, I would have for the way you treat me mother, so you can just cut it out. And that pulled us up with a jolt, because I didn't really think of anybody else. I was thinking of myself all the time inside.
The most obvious consequence of a laryngectomy is losing the voice box. But there are other considerations. The air that's breathed in comes direct from the stoma in the neck. That's not the way nature planned it.
Normally when we breathe through our nose and mouth, this moistens and warms the air before it hits our lungs and filters the air. A laryngectomy patient, because they're breathing directly into the trachea through the stoma, lose the filtration and the humidification and the warming mechanism of the nose. This leads to increased production of sputum or phlegm from the lungs. This might then lead to infection, lung infections.
Individuals who've undergone surgery will be more prone to chest infections, both in the immediate post-operative period and over a longer period of time.
In order to clear the secretions, because they haven't got the larynx to build up pressure in the lungs, the patient has to learn a slightly different technique of clearing phlegm from the lungs.
You know when it's coming. One good cough, probably about 3 or 4 times a day. That'll clear me chest.
You've got to try to keep your neck covered, especially when you're outside in the cold weather, in windy conditions.
I think all laryngectomies should be sent abroad in the bad weather, on the